Hey, welcome everyone. Thank you for joining us for our first Meet the Author conversation of 2024. For those of you that don't know me, I'm Priya Batija and I'm the founder and CEO of New Health. And for those of you that don't know New Health, we are a company focused on improving access to health and healthcare for women. And we do that in a number of ways. But one way is through bringing together people to talk about women's health in different formats. So we have our What's New events that take place once a month and where we have candid conversations about different aspects of women's health, everything from reproductive rights to sexual health and menopause. And we have an event coming up later this month on maternal health. And we also have conversations with authors of books that we've read that we think other people should be reading. And so thank you for joining us for this conversation today. We are joined by Anjana Sreedhar, who wrote the book, Healthcare of 1,000 Slights. And I'm just really excited to be here with Anjana to talk about the book, sort of her experiences, why she wrote the book, and some of the messages in the book about women's health. We'll talk for about 20 minutes and then we will open it up to the audience for questions. So please feel free to put your questions in the chat box throughout our conversation. And of course, if you don't have questions, I always have a ton of questions. So we will go for 30 minutes. And if y'all want to stay on longer to talk a little bit more, we can do that after the 30 minutes is over. So let's get started. Anjana, thank you so much for joining us today. Can we start by just having you tell us a little bit more about yourself and your background?
Absolutely. Thank you so much, Priya. I'm really excited to be here and talk about my book with you and with the community that you've built with New Health. So a little bit about me and my background. When I'll take you all back to college because I did have a pivotal moment that happened for me there. So I originally wanted to work in international relations and diplomacy, and then I pivoted slightly to global health. But around the time I was graduating, that was really when repeal and replace for the Affordable Care Act was really on the scene politically. And it got me thinking about really large conceptual questions around why the American healthcare system is built the way that it is. Why is it that in one of the most economically advanced countries in the world, we have such a broken, disjointed way of providing healthcare to people? So, with that in mind, I actually worked in healthcare best practice research for topics like patient experience and best practice and pharmacy strategy. And I decided to pivot once more and realize that it would be important for me to get an understanding of how healthcare is actually delivered, which led me to a role in hospital operations at an academic medical center in New York City. And now, instead of working inpatient, I now work on the same for outpatient at a cancer center. So that's sort of my winding journey into all things healthcare in my career.
Yeah, that's great. And I love that in healthcare, you can do a million different jobs and still be within the same industry. And we were talking about this earlier, but one of the things that I love about your book, and here's the book if you all have seen it before. One of the things I love is how you take that personal experience you've had throughout your career, intermix it with real stories of patients that are sort of going through the system, but then also research to show what is happening. And I think you do a really nice job of sort of elevating the issues without making us feel the doom and gloom that sometimes we can feel in healthcare. But what led you to write this book, and what did you really want to share with the world?
Thank you for that question. I think for me, around the time I started researching for the book or even thinking about the idea for the book, COVID was slowly unfolding
Mhm.
around the world. It hadn't quite hit the United States yet, but it was slowly unfolding around the world. And what that made me think about was, eventually this is going to make its way to the United States. And when it does, who is it going to impact more disproportionately? And who is going to find mechanisms and resources to stay safe? So, with that in mind, I started thinking a lot about health disparities. And again, the question that I kept coming back to was why, right? Why are these health disparities in place in the ways that they are? And so, with that in mind, I decided to do a little bit of research. And for me personally, I'm a big fan of all things history and policy related, but I recognize that for folks who are interested in healthcare, they may not always understand how a lot of times non healthcare related cultural, social, political, economic policies have
Right.
had such an impact on people's lives and to a certain degree impact on their health that has had intergenerational impact. So something that might have happened or a policy that might have been passed in the 19th century continues to live on in terms of how it's impacted people's health now. So I started to thread together some of these stories and realize that so many things are interconnected, right? The way the neighborhoods that people are allowed to live in, the kinds of jobs and education that they have access to, all of those things are so interwoven in their quality of life and therefore in their healthcare experience and their health outcomes. So as I started to make these connections, I realized that there's actually a really interesting narrative to be able to tell. What is the connection between everything that's happened in our past in American history and how that past has impacted health outcomes of today?
Yeah, and I think that's something that even those of us that have been working in healthcare for a long time are still learning, right? We're learning all the different ways and the different laws and regulations that set up our society the way that it's set up today have actually led to poor health outcomes for certain populations. So throughout the book, you talk about this history of our country and the results of that legacy. Can you make that more direct connection between that history and health and maybe give us some examples?
Absolutely. So I think for the purposes of this conversation, I'm going to laser in specifically on women's health. And I just want to point out that there are so many downstream effects from historical decisions that were made a long time ago that have impacted how women are treated in the context of their health. And I think some of that doesn't necessarily have to be a policy or a law that was
Mhm.
formally passed by a government. A lot of it can be cultural notions as well. So this idea around hysteria, that women, anytime they bring up any kind of issue with their body, whether it's pain, discomfort, anything along those lines, that makes them hysterical. And if we even think about the etymology of that word, when a woman has her uterus removed, what do we call it? We call it a hysterectomy, because the idea was that that's where women's emotions were located in their reproductive system. And as a result, they were incapable of making decisions, not just about their health, but about, jobs and marriage and things like that, which is a slightly different topic, but still altogether connected. The other context to keep in mind too is cultural notions around women and pain. So
Mhm.
the idea that women deserve to be in pain because they are biologically made for childbirth, for menstrual cycles, for other really painful experiences means that they are strong enough to handle it. So those are all examples of cultural notions that have impacted how women have been seen in the context of their healthcare. So there's that component of it. Then there's also the component of what I like to call boobs and tubes, which is, sexual health and reproductive health and how women's bodies have constantly been regulated throughout history, whether that's during the time of slavery, how enslaved women were regulated. And, if an enslaved woman was sexually assaulted by a slave owner, her children were automatically enslaved people and she had no control over what would happen to them. So that's, one example of
Yeah.
a past policy that has that impact again on women's health and on women's lives. And then finally, there's, the non-sexual health, reproductive health components of women's care. And something you and I have talked about is that
Mhm.
women were not allowed to be part of clinical trials until 1993, which was
Yeah.
30 years ago. And as a result, we still don't always have an understanding of how certain drugs interact with women's hormones and how enzymes in women's bodies break down drugs. And a really good example of this is Ambien. So Ambien is responsible for obviously helping people get to sleep, but one of the side effects of Ambien is that it increases the rest period between heartbeats, known as QTs. So women actually have longer QTs than men do. So if a woman takes Ambien and she is given a prescription that would be, the same prescription a man would get, it might lengthen her QTs even longer, which could result in arrhythmia or further heart complications. And again, that's not something that we would have learned had women not been involved in clinical trials much, much later on. So those are just some examples of things that have happened in the past, whether they are cultural, historical, or policy driven, that have impact on women's health now.
Yeah. And so all of those things you talked about, sort of the cultural aspects of our society that have led this, I think that has all led to a concept that you talk about in this chapter on women's health called the trust gap. So
Mm-hmm.
can you explain maybe a little how that all flows into the trust gap, what the trust gap is?
Yeah, absolutely. So I think there's, just to kind of zoom out of your question a little bit, I think there's the trust gap and there's the knowledge gap. So if we start with the knowledge gap is basically what I was describing. so far, which is that as a result of women not really being formally included in medical decision making, we don't have a lot of information on how women's bodies process drugs. We don't have a lot of information on how to successfully treat certain specific diseases, whether it's endometriosis or fibromyalgia, which men get too, but affect women at a much higher rate. So that's the knowledge gap piece. And then the trust gap piece is just acknowledging and identifying the fact that women don't have a lot of trust in their providers, and that comes from regular experiences of being either gaslit or being made to feel that their pain isn't legitimate, or having to be in a position where they have to go to several doctors to get something checked out. And the story that I bring up in my book is the story of this one patient who was constantly experiencing pain starting in her early 20s. And every time she would go to the doctor would say, it'll go away in a few days. You're making a big deal out of nothing. And it turned out by the time she was 50, she was successfully diagnosed with psoriatic arthritis. Now, if this person had received the appropriate diagnosis 30 years earlier, her quality of life would have been much more improved. But because there was this lack of trust between her and her provider, both ways, right? The provider didn't trust her to actually report her pain accurately, and then as a result, she couldn't trust her provider to give her an appropriate diagnosis. She is now in a position where 30 years after this pain has started, she only now has a way to actively deal with that pain.
Yeah, and there's so many women that are sort of living and waiting and hoping for the diagnoses of what is causing their pain. Are there other ways you've seen the trust gap show up and sort of influence women's health outside of waiting for a diagnosis? Or yeah.
Yeah, no, absolutely. I mean, I think a lot of what I'm describing with respect to the trust gap has to do with when a woman is successfully able to make it to the doctor's office, right? But the trust gap can also manifest in a lot of other ways, where a woman may struggle to even make an appointment about
Mhm.
for something that she's dealing with because the person on the phone may not trust that she actually needs that appointment. So I think something else to think about is what are all the different barriers to care? So obviously, when you actually make it to the doctor's office, it's not a guarantee that you will actually access care. But then there's also the steps right before
Yeah.
the lead up to it that may not necessarily be directly related to the trust gap, but by the time the woman has surmounted all of these obstacles and gets to the doctor's office, it can be difficult for her to trust the provider to make the right decision for her, because a lot of women, like you were saying, have experiences where they have been let down by the medical system or have been told that their pain isn't legitimate.
Right, right. So how can women advocate for themselves in light of the knowledge gap and the trust gap that you've described?
I'm really glad you're asking that question. And I just want to start out by saying, first of all, it is highly unfair that we even have to be asking this question to women, that
Yeah.
women have to do this extra labor of trying to figure out how to be taken seriously when they get to the doctor's office. But with that said, a couple of easy examples. We'll start with low resource examples, and then if you have more time and resources, there's more
Mhm.
you can do, obviously. The first is actually keeping track of your symptoms when they manifest, like keeping a diary, almost like, this is my pain started on this date, this is how long it lasted, this is how it made me feel. So that way you're able to show up to your doctor's office with a pattern of pain that you can actually demonstrate and share with them. I think the other thing too is recognizing what the current state of what the doctor patient relationship looks like. It is no longer the case where anything that the doctor says goes. And there should be an acknowledgement and an understanding of, you have the opportunity as the patient to be empowered in your care. So if you have the opportunity to politely push back and say, hey, I actually mentioned that I was in pain earlier. Can we revisit that? Or is there anything else that we can do to take care of this situation? Because it's really impacting my ability to live my life. So that's another piece of it as well. And then, of course, if you have more time and resources, other examples include, joining patient advocacy groups, patient family advisory councils that a lot of hospitals and health systems have, and joining support groups. Sometimes if you aren't able to do anything else, hearing from other women who are going through the same challenges can really build a feeling of community support and solidarity. And the last piece, again, kind of tying everything back to the clinical trials, is signing up for those clinical
Mhm.
trials if you are indeed eligible, because that way, the more information we have about how women's bodies interact with these drugs, the more likely it is that doctors will be more aware that they need to prescribe.
Yeah. And I'll just sort of make the point. I mean, it's been 30 years that women have been required to be in NIH funded studies, but it really hasn't gotten us to where we need to be. And women's health continues to be under researched. So we're not looking at sort of the conditions that are impacting women differently or mostly or only impacting women, right? And so there's still huge gaps. And then outside of NIH funded research, there's even bigger gaps, sort of including women. So I love that point about being proactive and being a part of these trials if you have an opportunity, because that can't change unless more women are part of the trials. I mean, we're not going to get the information unless we have that. So I'll ask one more question, and if anyone has questions, please feel free to put them in the chat now. But your book focuses a lot on hope, right? And what gives you hope as you think about women's health in the future?
Honestly, I think it's been seeing the emergence of more and more companies that are focused on women's health, like New Health, but also to see in the startup space, people are really starting to be committed to all these different facets of women's health. So, what's been interesting for me to see is the number of not just startups that are looking really closely at women's fertility or, menopause or, menstrual cycle tracking, but also startups that are looking at how to provide better whole person care to women
Mhm.
specifically. And I think it's really interesting to think about that because, even in the examples that I just mentioned, women go through so many bodily changes throughout their lives, and that ultimately has an impact on their non-reproductive health as well. So if you're somebody who's dealing with very severe menstrual cramps that might show up in your health in other ways. It might create anxiety, it might create high blood pressure. So how are we kind of tying everything together? And I think we are now seeing a new era where, even venture capital is starting to say women's health is something we actually need to invest in.
Yeah.
We actually need to start collecting data on women's health and also more importantly on how certain diseases show up in women, diseases that may show up across the entire population, but how they might show up differently in women. So I'm definitely hopeful for the future because I think we're starting to see an increased focus on a lot
Mhm.
of these topics from a startup perspective, from a data collection perspective, and also from a news and narrative perspective. I think in the past couple months, I've been seeing more and more articles about topics like hyperemesis gravidarum, which people are like, what does that even mean? But it's basically if you have like very, very extreme morning sickness throughout your pregnancy that, causes you to vomit severely several times a day beyond what would be considered normal morning sickness, that's not something that people are aware of or something that's even
Mhm.
widely studied. So you have a lot of women who are experiencing this throughout their pregnancy with really very limited recourse. So it was exciting to see a publication as prominent as the New York Times really focus their energy on this is a topic, this is a health issue that's affecting a lot of, women experiencing pregnancy, and we need to do something about it.
Yeah, 100%. And I applaud you for saying the medical term for that condition, because I always just say HG because I don't know how to pronounce it. So, but yeah, I agree with you on that. I think there's so much more being written and so much more conversation around women's health. It really feels different. And sometimes I wonder if I'm just in my own women's health echo chamber. So I feel like there is a lot being written about it. But even within that echo chamber, there's so much more today than there was 2 years ago or 4 years ago. So agree with you on the hope there. But we do have one question in the chat for you. It's from Lori. She says this is such an important topic. How do we find out about clinical trials that we might be able to participate in, and what are the risks of joining those trials?
So I think, as far as I'm aware, some of the best ways to find out about clinical trials is obviously, ironically, through your physician. And if you are, going to a physician that understands, what cutting edge technology there is or what cutting edge treatments there are, they can recommend clinical trials to you. Another opportunity is to kind of browse around the NIH website. They keep track by law of all of the clinical trials that get funding from them. So you can kind of dig around and see what's appropriate, and they usually list eligibility criteria there. The one thing I will say before I answer the second part of the question is one of the biggest challenges with clinical trials and getting appropriate representation in clinical trials is that oftentimes some of the eligibility criteria can automatically knock out certain populations. And the reason I bring this up is because something that I haven't mentioned so far is that women don't just live in their identities as women, they're also holding on to a lot of other identities as well, in terms of race, ethnicity, sexual orientation, et cetera. And it's unfortunately commonly known that women of color experience much higher rates of things like high blood pressure, anxiety, depression, et cetera, that might automatically make them ineligible for clinical trials. So that can be one of the challenges. It's sort of a chicken and egg problem. Like all of these populations experience higher levels of these, comorbidities or pre-existing conditions, which make them ineligible to participate in clinical trials that could actually provide breakthroughs for them. So I just wanted to call that out very quickly. But then to answer the second part of the question, some of the risks, I think obviously one of the biggest risks is you might be in the placebo group, which means that you might not be receiving the actual medication because they're trying to compare the impact of the medication versus, not having that medication. And I think obviously from a clinical perspective, it's very important to kind of talk to a physician about what the actual medical risks could be of being part of a clinical trial. But I think that's part of why they have stringent eligibility criteria, because they want to make sure that if you do participate, you don't suffer any medical consequences as a result.
Yeah. Well, as we wait for more questions to come in from our attendees, what was one of the most surprising things that you came across when you were writing this book, whether it was in the women's health space or just generally as you were doing the research?
I think what I found most surprising and also most impactful is how a lot of these systems are layered to create disparity. So, for example, in order to prepare to write this book, I read The Color of Law by Richard Rothstein. And that book is all about the impact of redlining and segregation and the restrictions placed on who can own homes in what parts of neighborhoods.
Yeah.
What was interesting about that is obviously there were actual policies that were written about, you can't sell your home to a Black person in this neighborhood. So obviously that's kind of concrete policy, but then there's also the cultural notions that support that policy. So even once, redlining became illegal, there was a lot of cultural support around, oh, well, we want to keep our neighborhoods homogenous. And that ultimately has an impact on who can continue to live in that neighborhood, decades and decades after a policy like redlining was made illegal. So I think for me, it was interesting to see how, as a result of policy, or perhaps even before policy, culture can have such an impact on shaping outcomes for people's lives. Again, not just health outcomes, but in this particular case, restricting where people can live.
Yeah, that's a really good point. There's another question in the chat. Kevin says, thanks for this, and then says, in what capacity do you see intersectional, including gender, racial, socioeconomic health issues and policies changing, optimistically or pessimistically, in the next 5 years or 10 years?
So, Kevin, thanks for this question. I think obviously asking this question during an election year is or federal election year is kind of very important to keep in the back of our minds. What I think has been really interesting is there's been a lot of laws passed, especially at the state level, to kind of limit access to things like gender affirming care, education around sexuality and sexual orientation. So I think there's obviously non-health policies that are being passed on more local levels that will eventually have an impact on mental health and on physical health of people in those states, which I do not feel optimistically about, unfortunately. So I think we'll see a lot of that play out, especially leading up to the election. I think something else that I'm always keeping in the back of my mind is what happened with Roe v. Wade in 2022 and how women's health, especially from an abortion/reproductive rights perspective, continues to be very, very contentious, because at this point it's very driven state by state, and there is an increasing surveillance of women who are trying to leave whatever state they live in to get abortion services or other reproductive care outside of their home state. So I think as a result of all of this increased surveillance, we will need to continue to keep our eye on how this is going to impact women's health, because I do see a lot of negative downstream effects from a lot of these policies being passed and sustained.
Yeah, absolutely. Another question from Sony, what areas could AI have a strong impact in closing the trust and knowledge gap in women's health that you mentioned?
That is such a great question. I think for AI in particular, I think it'll be really helpful to see how AI can inform a lot of medical education, not just at the medical school level, but also like continuing education for physicians and others who provide healthcare, because a lot of AI is really just sourcing from existing education and be making that more accessible to people. So I have a lot of faith in AI being really helpful for providers to better understand, how to take care of women, especially women who are experiencing some of these health issues that have not been very well researched. And I think from a trust gap perspective, AI is again another tool that female patients can use to kind of better inform themselves. So again, when we were talking about, I should have mentioned this when Priya asked the question, how can we better advocate for ourselves? AI can be a tool in which we access to generate some of that education for ourselves, so that when we go to the doctor's office, obviously with the recognition that we may not have clinical degrees ourselves, but we've done our homework in terms of this is what I've been seeing, this is the research that I've been looking into. How do you think this can help me?
Yeah, that's great. And thanks for tying it back to sort of that how we can advocate for each other. Um, so we've got 3 minutes left, and I guess I will just end by asking you, is there anything that you haven't covered that you'd like to cover about the book or where healthcare is going, or women's health?
Yeah, absolutely. I mean, I think what's really important to keep in mind is healthcare in the United States is always going to be very nebulous. And this kind of ties back to Kevin's question about like, where do we see healthcare in 5 to 10 years? I think we can kind of predict general trends, but at the last minute, a policy could be passed, a Supreme Court decision can be made, and that can really impact everything that we need to be doing to keep those policies implemented or not implemented. So I think that that's the only thing that I would share with the group, is that healthcare is very regulated in the United States, and as a result, things are always on the move and always changing. And that obviously makes things very difficult for female patients and for other kinds of patients too, because they always kind of have to keep their eye on what's going on. But that's where I see healthcare in the future. We're continuing to be in an uncertain landscape, and unfortunately, we have to continue to keep our eye on what's going on.
Yeah, very good point. And it makes it a little stressful, but always exciting to be part of healthcare and the healthcare delivery system. So, Anjana, thank you so much for writing this book and for taking the time to be with all of us and to share your thoughts and insights from all the work that you are doing in your day job and the research you did to put this together. We really appreciate it. And thank you to all of you who have joined today to be part of this conversation. We do have another conversation coming up in 2 weeks on February 29th, and we have brought together 3 sort of national and leading experts on maternal health to talk about the maternal health crisis and what we need to be doing moving forward, not only as a healthcare system, but as individuals, and how we can advocate for ourselves and the ones that we love. So I hope you will join us for that. I put the link to register in the chat if you are interested. And thank you again for your time. And we look forward to seeing you at another New Health event in the future. Thanks.
Thanks so much, Priya. Bye, everyone.